All right.
My name is Tammy Deason, and this is a presentation on reduction and prevention of pressure ulcers in critical care patients. The purpose of the presentation is to present information on pressure ulcers to include the prevalence and incidence of pressure ulcers and how to prevent or reduce them. The problem is that they can be reduced or prevented when evidence-based practices are implemented and followed, but unfortunately that's not always done. This presentation will cover interventions that can be used to prevent or reduce pressure ulcers and the outcomes that can be achieved. Critical care patients are most at risk for pressure injuries and require more detailed attention in order to prevent injuries. Pressure ulcers are also referred to as bed sores or decubitus ulcers, and they can develop quickly. They are injuries that occur to skin and underlying tissues that result from prolonged pressure on the skin, especially skin that covers bony prominences such as the knees, ankles, hips, elbows, and tailbone. Some facts about pressure ulcers is that they are an ongoing problem. They result in longer and more expensive stays in the hospital, with an average of 2.5 million being affected each year, with the average cost per individual ranging anywhere from $20,900 to over $151,000 per pressure ulcer. Critical care patients are at higher risk of developing pressure ulcers due to hemodynamic instability, immobility, use of vasopressors, and just the number of devices that are used for their care. For patients that only have a short stay, the risk of developing a pressure ulcer is only about 13%, while the risk for a long stay is about 42%. The United States sees annual costs related to pressure ulcers that are approximately $1.1 billion per year. The development of pressure ulcers, as well as the progression, can lead to sepsis or even to death. Vasopressors can cause reduction in tissue perfusion due to their vasoconstrictive activity. Therefore, patients that are on vasopressors are at higher risk of developing pressure ulcers. Patients on vasopressin or norepinephrine are likely to have higher incidences of pressure ulcers. And those that are on vasopressin alone were found to be 5 times more likely to develop pressure ulcers than patients that were not on vasopressin. Some objectives of this presentation is to educate in order to heighten awareness as it relates to the incidence and prevalence of pressure ulcers and the effects it has on both patients and the hospital. Introduce the Inspire bundle, which will provide information on how to conduct systematic assessments of the skin, as well as to help determine those patients that are most at risk for pressure ulcer development. Discuss turning schedules and turning teams to help ensure that patients are being turned in a timely manner. Pressure ulcers can be prevented, thus the need to set interventions in place that can help to reduce or alleviate the incidence and prevalence of pressure ulcers. Some of the benefits of reducing them are that hospital stays will be shorter with lower rates of infection. There will be a decrease in morbidity and mortality. The hospital will benefit from decreased costs because insurance companies don't pay for the cost of pressure ulcers if they develop while the patient's in the hospital. The hospital eats those costs. With a decrease in the incidence and prevalence of pressure ulcers, the patient will benefit in that they will have a better experience and a higher level of satisfaction. PICO question to go with this project is: how do methods such as turning schedules, bundles such as the Inspire bundle, use of clinical guidelines for pressure ulcer prevention while in the ICU, and increase staff education and awareness compared to the current policy that we have for prevention measures? The importance of prevention, 95% of pressure ulcers are preventable if you just take the right measures. Pressure ulcer occurrences are quality indicators. Pressure ulcer development will diminish a patient's quality of life. They will lead to increased length of stay, increased morbidity and mortality, and increased rates of infection. They lead to increased costs for the hospital and reflect negatively on the hospital. And the Joint Commission lists pressure ulcer prevention as part of the National Patient Safety Goals. Interventions that will lead to prevention are: number one is education. Education of the staff is an important factor, and it will lead to increased compliance and buy-in if we do the right kind of education. We need buy-in from both management and staff, and education on the why is real important. Why we need to check the skin, why we need to do these interventions. Education needs to include how to care for these patients that are too hemodynamically unstable to be turned on a regular basis or to be placed in rotation. Education should also include how to care for those patients that are on vasopressors, since they're at higher risk of developing pressure ulcers. Overall, we need to educate to bring about heightened awareness about both the incidence and prevalence of pressure ulcers and the interventions that can help to reduce and prevent them. The Inspire Bundle is a patient skin integrity protocol that is evidence-based and is used for critically ill patients. It provides a systematic approach for assessing the patient's skin, how to determine if they are at higher risk for development of pressure ulcers, and how to determine and conduct follow-up assessments. The follow-up with implementation of prevention measures that are tailored to prevention of pressure ulcers. The Inspire Bundle, when compared to the Braden scale, is more specific for patients that are critically ill. The prevention process in the Inspire Bundle is geared toward nursing assessment and documentation, hygiene of the patient, and repositioning of the patient. Research indicates that critically ill patients that were subjected to the Inspire Bundle rather than the Braden scale had a decreased incidence of pressure injuries from 30% down to only 18%. The same research also showed a decrease in the amount of time it took the pressure ulcers to develop and the decrease in the severity of pressure ulcers. Changes with the Inspire Bundle include when the patient arrives, a full skin assessment and documentation should be completed within 4 hours rather than the current 24 hours with a reassessment every 12 hours. For patients on ventilators, reposition of ET tubes every 12 hours and change the support equipment as needed. Encourage ambulation periods earlier and earlier getting out of the bed. Daily baths with pH balance agents such as chlorhexidine cloths. Turn the patients at least every 3 hours. Eliminate pressures to bony prominences and heels with Alevins and other protective padding. Inspire versus the Braden scale. The Braden scale is not sufficient to reflect accurately the characteristics of critically ill patients. The Braden scale has insufficient predictive validity as well as poor accuracy when it comes to discriminating critically ill patients that are at risk for pressure ulcer development. The Inspire Bundle has been proven to be a much better predictor for critically ill patients. Another prevention would be turn teams and turn schedules. Establishing turn teams and schedules to help ensure that all patients are turned in a timely manner, in a more regular manner, and it'll set the scene for creating an environment of teamwork. The turn teams can include nurses, the techs, and members of management because primary care should be our focus, or patient care should be our primary focus. Turning the patients on a regular basis will relieve the pressure and allow it to be redistributed to other areas, thus increasing the blood flow and reducing chances of pressure injury development. Pressure ulcer prevention team would be a team that would be established and be tasked with the responsibility of working toward prevention. This team would be responsible for developing new policies, conducting periodic reviews to ensure that the policies are adhered to, ensure that appropriate interventions are being used based on the individual patient. They would be responsible for conducting ongoing education and presenting new research as it comes about. Alevins for prevention. The Alevins are an advanced layer dressing that's used for wounds. However, they're also used for preventing wounds. They come in all shapes and sizes and can be placed on any bony prominence to provide padding and prevent injuries. They're also available for heels to protect the soft tissue from breakdown. And there's some pictures of the different kinds of Alevins that are available. Some nursing actions would be to assess your patient within 4 hours of admission for skin issues and potential breakdown and reassess them often. Apply sacral Alevins on admission and heel elbow Alevins if the patient is immobile or ventilated in order to protect those tissues and reduce breakdown. Establish a turn schedule for each patient and ensure that it's adhered to. Establish necessary precautionary interventions for those patients that are immobile, ventilated, hemodynamically unstable, or on vasopressors. Stay on top of research and evidence-based practices as they relate to pressure ulcer prevention, and share information with your fellow coworkers. And then document everything that you do to prevent those pressure injuries. To evaluate the success, it would be evaluated by a proven decrease in the incidence and prevalence of pressure ulcers in critically ill patients. The data would be collected from before and after implementation of the interventions and compared to determine the overall success. Management would gather data to review for compliance with preventative measures, such as skin assessments being done in a timely manner, turn schedules being adhered to, and placement of a leave-ins when appropriate. The goal for the critical care area would be to see improved compliance with interventions and policies greater than 90% after the first 6 months of implementation and greater than 95% at the end of the first year. Reevaluations of interventions and policies need to be performed periodically by the pressure ulcer prevention team in order to ensure that they're bringing about the desired reduction in injuries and making changes as necessary. Expected outcomes will be decreased incidence and prevalence of pressure ulcers, decreased cost to the hospital, decreased length of stay, decreased rate of infection to include sepsis, decreased morbidity and mortality, better patient experience, and higher levels of satisfaction from the patients. In conclusion, pressure ulcers are an ongoing problem, especially in critically ill patients, but the majority of them are preventable. The most at risk are those that are hemodynamically unstable, immobile, on vasopressors, or have numerous devices used in their care. Prevention measures include education, the turn teams, a pressure ulcer prevention team, the Inspire bundle, and a leave-ins for prevention. Evidence-based research provides guidelines for prevention of pressure ulcer. Prevention saves money and lives and makes for more satisfied patients. So be proactive with your patients rather than reactive. Any questions? Thank you.